Thanks, Mina. So this is a paper I worked on a few years ago with Amanda, who you just heard speak, that's in the Journal of Epidemiology and Community Health if you're interested. And it's part of a broader package of work I've been working on looking at the link between housing and health. So just a bit of background context. So housing is obviously an essential determinant of health, both in terms of physical and mental health. There's a long history of people linking the two. So going back to sort of Engels' work on the conditions of the working class in England, Seaborn Roundtree's work on the inadequate and insanitary housing of the struggling poor in York, and then Britain's work on slums and the high mortality rates found within them in the 1930s in the US and UK. And there's a tendency in this early work to focus on the physical conditions of people's homes. And as time's passed, this is increasingly focused on broader elements of housing, such as affordability and security. And Mary Shaw characterised these as the hard and soft components of housing. So the hard components being the physical, and the soft being the more social, psychological components of housing. And there's been a tendency, I think, to think that, you know, we've sort of passed the physical now, but I think it's important to reflect on the fact that these issues aren't solved. We saw the Grenfell Tower fire, for example, the continued presence of flammable cladding on other people's homes, the recent focus in the media on very poor conditions in some social housing, and people unable to maintain safe homes where they're responsible for their maintenance. So as well as the soft and the hard components of housing, you can consider the impacts of housing on health, in terms of direct and indirect effects, and just some examples sorted according to this sort of categorization. So things like exposure to cold and damp, that's one of the largest areas of evidence linking housing to health. It's got direct effects, particularly on respiratory and cardiovascular health. So it's linked with high blood pressure, for example, but also mental health problems, digestive problems, and more general symptoms such as headaches and migraines. And there's obviously the large literature linking, or the decent literature linking cold homes, poor quality homes to excess winter mortality. Indirect effects of the hard components of housing include things like overcrowding on children's ability to do well in school and to do their homework, effects on social life, living in a home that's either too cold, so people go to bed very early because that's the only way to maintain some kind of suitable temperature, or just because of the stigma and shame surrounding living in a home that's not of a decent quality. In terms of the soft direct impacts, there's things like poor housing affordability, which creates stress and is linked with anxiety and depression. So, for example, in a paper, we looked at the impacts of cuts to housing benefit and found that the people affected reported increased likelihood of experiencing depression. And the indirect effects of things like this, such as affordability and security, are crowding out spending on other essentials. So the heat, or sort of like the heat or eat dilemma, but with housing costs. So you haven't got the income to meet your rent payments and eat 3 decent meals a day that are of suitable quality, and also things like insecurity and having to move regularly are impacting on people's ability to maintain a consistent relationship with healthcare providers. So children who've moved regularly are less likely to have had all their vaccinations, for example. But their relationship is bi-directional, which is important to remember, and poor health will affect ability to secure safe and affordable housing. And there's also the interactions between these different characteristics. So while there's a tendency to study housing in terms of its affordability or its quality separately, there'll be knock-on effects. So an unaffordable home is likely to be one that's hard to maintain because the costs are going on paying for it rather than leaving any money for maintaining it. Where housing is unaffordable, people are more likely to experience things like overcrowding or poor quality. So again, for example, looking at the impacts of housing benefit cuts, we found an increase in risk of overcrowding among those affected, and things like poor quality homes that will be harder to heat and therefore less affordable. So it's a complicated but an in-depth relationship. So this just summarises the growing body of evidence linking housing and health, but much of the evidence relates to specific health conditions or self-reported health, which is obviously great, it's really useful evidence. But what the biomarker data has enabled us to do is provide an opportunity to explore the association between housing, health and health in a slightly different way. So for our paper, we looked at C-reactive protein. So that's a protein found in the blood that is associated with stress and inflammation. So, and we felt that was a good way to pick up the range of different ways that housing influences health. It's been linked in the past with things like employment status and socioeconomic status or positions. So we felt that this was a good way of picking up how housing is affecting people's health broadly. Higher levels of CRP indicate worse health, so more stress or inflammation. We excluded people, though, that had very high levels of CRP because this tends to indicate a recent infection rather than the general health of a person. And while a recent infection could be broadly related to housing, we can't obviously check that it could be unrelated. So we excluded those people. Similarly, we excluded the very young because we were the youngest in the survey because we are interested in their housing situations. So because under 22, so 21-year-olds, they might be at university, they might be living with their parents. It's a slightly different housing situation than people who are older. And we also excluded those that were at the very high end of the age scale because of low sample numbers and things like that. As a result, we had a sample of just under 10,000 people across the 2 waves of the survey where biomarker data were collected. And we linked each wave of biomarker data to the respective survey. So if people provided biomarker data in wave 2, we used that wave 2 survey response, and it's the same for wave 3. In the main analysis, we control for a number of confounders are linked with both people's housing experiences and their C-reactive protein levels, such as age and gender. And we account for medicines that people are taking that might affect their C-reactive protein levels. So I think, if I remember correctly, it was things like statins. And we explore the impact of housing very broadly. So we include all of the suitable housing variables that were available in the survey. So we include tenure, so whether people were renting or owned their home, and whether it was a private rent or a social rent, as well as whether it was owned outright or they were paying a mortgage. We looked at housing payment burden, so whether or not the household was spending more than a third of their household income on housing costs, while their income was below 60% of the median. So that brings in both a low income and high expenditure approach to housing payment burden. We also had a binary measure of housing payment arrears, so whether people reported being 2 months or more behind on their housing payments, whether they're receiving housing benefit. So we had 2 measures related to ability to keep the home warm, one relating to having central heating, and one relating to reporting being able to keep the home adequately warm. We included overcrowding relating to bedrooms per person or couple in the household, dwelling type, so the type of building that people were living in, whether it was a flat, whether it was a terrace, whether it was a detached home. Previous research has found that to be linked with people's health, and whether people preferred to move, expected to move, and an interaction between the two. So we could try and pick up people who wanted to stay but felt they were likely to be forced to move, and people who wanted to move but felt that they were likely to be forced to stay where they were. So trying to pick up as much of the different aspects of housing and how it might influence health as possible. So first of all, we looked at just reporting C-reactive protein levels according to these different characteristics. I've shown some here. So we've got tenure on the top left, housing payment burden top right, building type bottom left, and overcrowding bottom right. And while there are, as you can see, differences, the confidence intervals tended to overlap. So although we control for age and gender in this, without broader controls, we didn't really find many statistically significant differences, which was perhaps surprising. But for our main analysis, we ran regression models and we did find some significant results. So we found that private renters had worse or higher levels of C-reactive protein, which we expected, given the nature of private renting. So while tenure itself perhaps isn't necessarily something you would think of as being directly influential, it has different consequences. So, for example, private renting in the UK generally and on average has the poorest quality housing. It's also the most insecure and the most expensive in terms of both costs outright and the proportion of income people spend on their housing. So while tenure itself might not be what you expect, I think this is picking up those different characteristics of housing that it's hard for us to pick up more directly using the data. We found that people in detached houses had lower levels of C-reactive protein compared to people in other types of buildings, which is consistent with previous research. It's found people in these sort of homes have a bit greater sense of autonomy and control over their homes. They're less likely to be disturbed by noise and other things like that. We did try to test for noise. We did a robustness check, but because experiencing household noise or noise from neighbours wasn't included in both waves, the sample size was lower, so we only included that as a robustness check. Similarly, and perhaps most surprisingly, we found lower C-reactive protein levels, so better health amongst renters who reported housing cost burden. But what we believe this is a great example of the interaction in a different way that housing components combine to create the housing experience. So what we think this is low-income renters choosing to live in a more expensive home in order to provide a better quality home. So to live nearer to their children's schools or to their workplace to ensure access to a home that has a decent quality standard. Of course, that's only in theory, and one of the limitations here was that we weren't able to include really any measures of building quality, physical qualities of the home, because the measures that were included in the British Household Panel survey weren't brought across to the Underlying Society survey, unfortunately. So that's our interpretation and best guess, but we couldn't directly test that. There were, however, some areas where you might expect significant effects. So like I've said, housing cost burden, tenure, there's elements there that are obviously directly relating to cost, but arrears were not statistically significant in the analysis. Thermal comfort wasn't, so the questions relating to keeping the home warm or having central heating, but there is a chance that's because of the gap between the survey question they've been asked and the biomarker collection. It's the same with overcrowding and same with wanting to move. So it may just be that, again, the gap plays a role, or that C-reactive protein is not the appropriate biomarker if we're interested in these particular questions. But nonetheless, we did find some interesting, significant impacts for tenure and private tenure, building type, and housing cost burden for renters. So there was, we think these results had a number of findings, a number of implications for policy. So the ability to ensure to have standards in the private rented sector, which until a recent announcement wasn't included in the Decent Home Standard, and to be able to ensure that any standards that are in place can be enforced. So local authority funding is in place to ensure that people who report problems with their housing, this can be followed up and acted on. The importance of affordable housing, so ending what are called affordable rents, which are calculated in relation to market rents rather than any meaningful measure of affordability. Local housing allowance / housing benefit rates being increased back to relate to the actual rents that are being paid after years of freezing and below inflation or increases. There's an argument, I think, this supports calls for increasing social housing, supporting Shelter's call to build more social homes, and to improve the security of private rented tenancies. Because again, the finding that people in privately rented homes have this higher level of C-reactive protein is quite significant. So I think that makes a strong case for improving conditions in the private rented sector. Thank you.